Hello, my dear doctors. Welcome to another episode of Doctor Academia. In this episode, we will be discussing about hypothyroidism. The topics I'll be covering today will be the introduction, clinical features, causes, investigation, and finally the treatment. Let's introduce hypothyroidism. Hypothyroidism is a condition where the thyroid gland does not produce T3 and T4 hormones. The prevalence of the disease is more in females than in males. When a patient presents to you with hypothyroidism, what kinds of symptoms and signs can you detect? See, the symptoms a patient with hypothyroidism presents will be weight gain, cold intolerance, dry skin and hair, menorrhagia, constipation, carpal tunnel syndrome, muscle stiffness, depression, infertility and galactoria, and psychosis. The point here you have to note is that how hypothyroidism causes infertility or galactoria. See, normally thyroid hormones inhibit prolactin. In normal circumstances, thyroid hormone inhibit prolactin. But when there is no thyroid hormone, prolactin can act indefinitely and causes infertility and galactoria. What are the signs you can detect in a patient with hypothyroidism? Weight gain, hoarseness of voice, purplish lips, Malar flush, periorbital edema, loss of lateral eyebrows, anemia, normocytic normochromic anemia, bradycardia, hypertension, and thermal myxedema. What causes hypothyroidism? It's a condition where there are multiple causes, and the most common being one on autoimmune disease, Hashimoto's disease, where anti-thyroid peroxidase antibody will be present and hypothyroidism will be shown. Iatrogenic, when there is a radioactive iodine ablation, thyroidectomy, or prolonged use of lithium. When there is a transient hypothyroidism, like in conditions like decurvine thyroiditis, postpartum thyroiditis. When there's iodine deficiency, and other conditions like dyshormonogenesis, amyloidosis, and Riedel's thyroiditis. When a patient is suspected of having hypothyroidism, what are the tests you will make him do? See, the first test you have to do will be the thyroid function test, where you'll be seeing decreased T4 and elevated TSH more than 20 in the international unit per liter. Why T3 is not used? Because T3 is not reliable in discriminating between euthyroidism and hypothyroidism. In autoimmune hypothyroidism, you'll be able to see thyroperoxidase antibody, and there will be also other metabolic changes. So you have to also test total cholesterol, hemoglobin for anemia, and hyponatremia. A patient of hypothyroidism is treated with the drug of choice, that is none other than levothyroxine, in the dose of 1.6 microgram per kg. In the market, it will be seen as thyroxine sodium tablets. In older individuals and those with cardiovascular diseases, you have to start the thyroxine tablets at a lower dose. That would be a dose of 50 microgram per day for a period of 3 weeks before increasing it to its estimated full dose. Why? Because a patient of cardiovascular disease or older individuals are very susceptible to metabolic stress. So it would be wise to start the patient with a lower dose and increase it gradually. The T half of levothyroxine is 7 days. Now, at least 10 weeks should pass before repeating thyroid function test as TSH takes several days to reach the steady state. So it would be wise to check the patient's thyroid function test after 2 to 3 months of taking the tablets. Then only the TSH will be reaching its steady state and we will get the correct values. The dose of levothyroxine should be adjusted to maintain the serum TSH within the reference range. For this, you have to check an important hormone, that is serum T4, which should be in its upper normal range because T4 at the periphery will be converted to T3, which is the active hormone. So you should be always be careful to check the T4 and make sure it is in the normal range. Whenever a patient takes extra levothyroxine or when he forgets to do a follow-up, it suppresses the TSH too much. In cases with low TSH, there will be an increased risk of osteoporosis and atrial fibrillation, etc. This condition is called subclinical thyrotoxicosis, where there will be undetectable TSH with elevated T3 and T4 at its upper end of reference range. And the ulta of this condition will be subclinical hypothyroidism, where the TSH will be elevated and the T3 and T4 is at the lower range of reference point. In this condition, if the TSH increases more than 10 milli-international unit per liter, or in this condition, if anti-TPO antibodies are present, then the patient can go into thyroid failure. So the best thing to do here will be treat the patient as early as possible. Thank you guys. Hope you understood this topic and please share and subscribe to see further videos.